Are you looking for a podcast where you can hear from real people regarding their real dental drama? If so, then you've come to the right place. Join hosts Bethany Petty and Dr. Rena Kuba as we dive into the solutions we've created and the mistakes we've made while managing dental drama. Let's get started.
Lady, it is almost time for summer.
I know. I'm ready.
I am so ready, even though it gets to be 1 billion degrees in Texas with the humidity. But I'm ready.
I'm ready too. Let's do it.
So I have a yay and a yuck.
Oh.
So you want to do the yay real quick?
Let's do the yay first. Let's start positive.
Okay. I'm super excited. You told me that we've been talking about this resource hub that we've been working on creating and spending hours upon hours of making resources available to colleagues and practice owners. Mm-hmm. And I think, the challenge with that is, for example, I think you had somebody reach out to you and say, can I, I'm about to onboard an associate, can you get me a contract? Mm-hmm. Now, you can find free contracts online, a bunch of them. Yeah. But I'm pretty sure most of us don't want that, and we kind of want to know how to, or it's a 60-page document, and we're like, for real, I gotta read this, then make sure the associate reads this, and then this sucks. So can you just customize one for me? And what about the legalities of the state I'm in, and maybe I don't want to do an associate contract, right? So your goal in creating this resource hub is what our goal has been for the podcast and for the subscription is the how. Mm-hmm. How am I doing this? One, so that I don't have a mental meltdown over this. Two, so that I don't bury my head in the sand and get somebody to sign something that's going to be actually a detriment to me. And three, without breaking the bank, because I know if I took this to a lawyer, God only knows what I'm getting. Am I going to get the 60-page document, the 30-page document? If I want it more customized, am I getting charged by the hour? So now I end up spending $2,000 on a contract. And so anyway, the resource hub is there to have these practical how-to documents.
Yes, and there's a ton of them, from associate contract to morning huddle samples to what's a written warning? How do I put that together? So many practice owners or managers just get stopped at that point of okay, I know I need to do a write-up, but what does that look like? And what's a good write-up? And so anyway, this hub is chock full of documents that are helpful, documents that are available for purchase, and it's a resource that we're going to continue to add. And
if I may give myself or us a plug in there for this, I think again, because y'all who've been listening, for me, I don't like the vague. I want to know, what do you mean? What does that mean when you say, these 3 steps, get your associate to sign a contract. In the contract, you need to make sure you put blah, blah, blah. What does that mean? What is the verbiage? What is the order? How am I actually executing this? So everything in the hub is something that I have laid my eyes on to go, would that be useful to me? Yeah. Because Bethany, you created this and that makes sense to you, but I'm still telling you, you're assuming that I know these 3 steps. And I'm telling you, I'm not that bright. That is your world, that's your everyday. But as the actual person who has to execute this, I have too many questions on those nitty-gritty details. And so everything on the resource hub should be as usable and user-friendly as possible, to where you may just need to tweak it to meet your needs. Yeah. So I'm super excited about that. So that was my yay.
That's a huge yay, and that's launching at the end of this week. So it's not live yet, but stay tuned for those of you listening. It will launch at the end of this week, and we are pumped.
We are pumped. I'm pumped to have these resources available for people. Do you want me to get to my yuck now?
Let's do it. We got to talk yuck at some point.
Okay. I really think this is a big yuck. And I think I'm about to be, I'm trying to prepare myself because I'm about to be in this boat. And It's been a little while since I've been there. And just the thought of it is making my stomach churn. When you are onboarding an associate, because we've had a couple of episodes recently here about associateships, and one of the big questions that I think all of us would prefer to dodge and would wish we had a wand to just make it happen is the clinical proficiency. So if you were to read any article about onboarding an associate, well, you need to make sure your clinical philosophies align. Okay, that we can all talk about from here to there, but when it comes to actually doing, how am I making sure? We could all say, and I'm sure we're all going to hear these iterations of, I'm looking for a practice that, patient care comes first and quality of care comes first, right? Like that's what every associate's going to say. Or flip side, the doctor's going to say, I need somebody who really puts the patient's needs ahead. That is still so stinking vague.
Yeah.
Who's going to walk in and say, my goal isn't to provide good patient care. I want to see as many patients as I can, so I'm going to do some crappy fillings, shove some stuff in there. I don't care what materials I use. Like, who's going to say that? Nobody. We're all going to talk about, like, this is our goal, in the practice to whatever. But how do you really decide, do we align on this? I just heard it just yesterday. I was talking with a practice manager who they're having a transition. The owner doc just sold, and so now new doc wants to put some stainless steel crowns on things, and the rest of the team is like, oh, well, we would have put a filling on that. Put a filling there. Like, all it needs is an MO composite. And I'm like, well, does it? Because I think for knowing that practice, it is a very preventive focused practice. There's not a lot of treatment needs that go into that practice just because the clientele that they see. It's a very educated, and they are doing a lot of the right things. So I don't think they get a lot of decay in that practice. And when they do, go the conservative route. But this new owner that's stepping in, I know the pool of patients she is used to seeing is a very high risk patient. So she's used to, so there's no right or wrong, but I can only imagine if I were to talk to this new owner going, the hell are they putting all these composites in there that are going to fail? Like, are they just trying to get more of this patient's money? Like, they're going to put a restoration they know is going to fail, and then a year later they're going to charge the patient again, and at that point insurance isn't going to cover it. And at that point we may lose the opportunity to, like, I can see high carries risk doc coming in with one mindset, and of course the office that as it's been is going, look at this aggressive doctor just wanting to put these ugly crowns all over the place. So digging deeper there, I'm sure when they spoke to each other, I'm sure the dialogue was, oh, nobody wants to overtreat, nobody wants to undertreat, we want to take care of our patients and do the right thing. But there's different ways to do the right thing. And so depending on which perspective you're coming from, I've heard the whole gamut of, oh yeah, you do oral conscious sedation. That must mean that you don't have any chairside manner. You want to make this easy for you. And then there's the flip side going, why am I torturing this patient when there are resources to help this kid? Yeah. And this parent would rather their kid not be tortured. So, how do you have those conversations? I'll give another example. I had a really sweet doc coming and helping me for a little while, and he was treatment planning MODs on primary teeth. And to me, that is a big no-no. And I know I'm probably ticking off half your audience now going, what do you mean that's a no-no? Well, I'm not going to get into the nitty-gritty of that, but to me, that is a no-no. And that's that. And so that's more of a, okay, yes, you barbarian, you just want to do your crowns and make it easy on you, or what are you talking about, an MOD on tooth number A? That is not standard of care. We both are right and we both are wrong, but that's one that I was like, if this doc had stayed in my practice longer, that's going to be tricky for me, because it's not a new doc. It's not a new graduate. Right. It's somebody that's been practicing for, not as long as I have, but not far from that. Now, how am I supposed to say, sir, you are wrong in your treatment planning? Like, that's just an awkward conversation that I don't really want to have. Yeah. So I guess that's where I'm going with this, is how do we, I think we could talk all day, but when it comes down to like actual doing, how are we looking at this new associate, whether they're a new grad or not? How are we going, I'm going to be looking at your treatment plans. Mm-hmm. And then how am I telling you if you're right or wrong? Mm-hmm. And if you as associate are going, yeah, please tell me, guide me on what's norm in your practice. But at what point are you going to go, you know what? You are really overdiagnosing, or you're really underdiagnosing, and I don't feel comfortable in this practice. I can't practice the way I want to. So my question to you for this uber yuck, you gave me an example, and I'm sitting here going, my current associate, I think we did have some initially awkward moments, me going, what are you doing, man? And I knew it was just the youth, like you are just starting to practice and you are going to come and see why that's not going to work for you. But he was so open to being a sponge to that and being open to me mentoring and guiding him. And it did mean he had to trust me.
Right.
He did have to see the why behind what I was saying. And he did have to experience some of the, okay, that's why she said what she did. I get it now.
Yeah.
And so I had to give him room to do that. He had to give me grace to go, okay, she does know what she's talking about. And we had to kind of trust each other. And so I think it worked really well. But now, fast forward 4 years later, I'm back in that boat again going, okay, I'm really scared of finding another provider that, and then you add on, okay, what if we are alike in our philosophies? Like, we've got to make sure we're on par there. But what about the actual execution? Okay, yeah, we did decide we're going to do a crown on this. And I think your crown is yucky.
Yeah.
And my assistant told me your filling was gross and it took you 45 minutes to do that when it should have, right? Like I don't have those issues with my current associate. We sorted that out pretty quick early on and now we're completely in sync. And to have to start over with that, I'm now going, okay, whoever comes in, am I just at the beginning saying, I'm going to be following your treatment planning? And this is what I'm going to be okay with, and this is what I'm not.
Yeah.
And then this is how I'm going to be auditing your chairside skills. Like, I just want to throw up thinking about all that because that is pretty disrespectful.
Yeah.
And am I going to turn off an associate? And then they go, you're batshit crazy, lady. You have control issues. I don't know. I'm at a loss. So I'm putting this to you. What are some of your thoughts, and then also what you just shared with me about an associate that left a practice. I'm gonna quit talking here and let you kind of share that. But again, this goes back to what I said a few weeks ago. Like, this is where we are not excited about onboarding an associate, and it is so much easier to go, never mind, I'm not doing this. But that's not practical either. I don't suggest doing that. There are a lot of good things that an associate can bring, but how can we be prepared for this? Do you have any nuggets of any heads up, any advice, thoughts?
Man, you weren't joking when you said yuck.
No, I wasn't.
I mean, like, you went into the deep, dark end of...
Well, I gave us a great yay. I went on the edge of that going, man, we've got some resources. Like, here we go. We're about to make people's lives a lot easier. And so it's only fair that I go completely to the other end.
That's true. That's, yeah. You've done both at 100%. So.
Well, and I guess I've kind of knocked you down because I gave you a high and a yay, Bethany, you got your portal going. And now I'm like, all right, Missy, what you got? Here's some yucky topics. Go ahead, expert.
Oh, so you said something that I stood out to me when you said this can come across as very disrespectful. When you're asking an associate, like, hey, by the way, I'm going to be watching your treatment plans, that can be super disrespectful. And I would say absolutely. There can be like a yuck factor to that, but I see it from the flip side and I go, this practice owner is putting their reputation, their liability, their patient retention, they're putting their implicit faith in an associate to handle all of those things well. And I think that's a very risky decision. So yes, there's going to be some awkwardness that in the things that I suggest, but I think that awkwardness is absolutely worth it to protect your practice and to protect your patient base. And at the end of the day, these are your patients. Every associate contract that you look at says that these patients belong to the practice owner. So these are your patients and you have to do what's right by your patients. And ultimately, managing or overseeing or having open dialogue with your associates is a part of that. So I think there's some things that a practice owner can do from the get-go. We need to set the norms from the get-go. And the norms are we're going to talk through treatment plans together. We're going to look at pre-op x-rays and photos. We're going to look at post-op x-rays and photos. You know, for the first 6 months, we're going to do a lot more intraoral photos after the completion of treatment so that we can look at those things together and dialogue about what could have gone better with this particular procedure. So you set this tone from the beginning. It's not, hey, I'm going to be watching you and I'm going to be looking for mistakes. We are going to collaborate a lot together. I'm going to show you some of my cases. I'm going to show you some of my treatment plans. I'm going to show you some of my pre and post x-rays and intraoral photos. We're going to dialogue together about my cases.
Even chart notes.
Yes.
That's another big one. I'm like, this is my expectation of your chart note. You put this down. But for me, that's not enough. And if I had to come in and I had to deal with this parent and this, I happened to be here and I saw or heard certain things, but you've left me no breadcrumbs in this clinical note. Yeah. Or I see that you're used to doing it that way over there, but we follow, like, to me, that, you know, these documents are important. I need you to make sure we've got this. So even down to including that part of it.
Absolutely. Yeah. At all the nitty gritty details. And when you are looking at the full case together, you're going to be looking at documentation. You're going to say, let's go look at that chart. Know what it is. Say, why did we do this? What was mom's rebuttal to this particular treatment plan? Here we go. This is why we did the alternative treatment on this tooth rather than this, because mom, blah, 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 blah. So it's a very comprehensive look at everything. Heck, I would say venture into looking at the financial documents that were put in for this particular patient. Make it comprehensive.
I even go down to the nitty-gritty of the appointment note.
Yeah.
So did you look at that and how did you incorporate that? Like, did you address the chief concern? Did the front schedule it the way it needed to be? Did you proactively approach the front? Like, if you saw that the front planned this for an SSC and nitrous and you knew you were going to need to take an x-ray, but you didn't bother to correct that ahead of time, and now you finished what you needed to do, but they didn't collect, but now mom is upset because, like, even down to those little details, making sure that they're connecting the dots from a whole flow perspective.
Absolutely. So if you set that stage from the get-go with your associates and you make it dialogue, it's not, hey, I'm going to call you into my office twice a month and I'm going to shame your treatment planning, or I'm going to be asking, what in the heck were you thinking on this? I'm not going and looking for your mistakes. We're just having a clinical collaboration, a meeting of the minds where we get together and we dialogue through a couple cases. Now, it's easy to do that if you set the stage from the get-go. Now, as you're interviewing associates, that can sometimes kind of be like, oh, what? You're going to be looking at my cases? No, we're going to be looking at our cases together and dialoguing because we want to make sure that clinically we're on the same pathway for our patients. That doesn't mean that the treatment plan that owner doc puts together has to be exactly followed by the associate. It just means that that associate is going to be getting insight into why the practice owner treatment plans this way or that way. And that should influence the associate. So we still want clinical autonomy. We want that doctor to be able to make his or her own decisions because that's important. There's some ownership that practice associate needs to take with each treatment plan. But the more that the doctor, the owner doc, and the associate doc are collaborating, the more that associate doc is going to then become like-minded with the owner doc.
Or not. And then you're going to quickly realize,
exactly,
this is not working. This is not okay.
Yeah. Now, if you're already in an associate situation, this becomes hard to then all of a sudden insert this. But I will say I have found very few times where, I don't think I've ever found a time, I'll be honest, that I didn't think it was appropriate for the owner doc and associate doc to collaborate some on clinical conversations. When that doesn't happen, here's what's the why behind all of this. At the end of the day, the care that patients are given falls to the responsibility of the owner doctor. So I can't tell you how many times I've sat with a practice owner that had an associate that, unbeknownst to them, were overdiagnosing, underdiagnosing, completely missing things, pissing patients off, and they had no clue, because the owner doc's like, oh, here we go, great, got a wonderful doc on the team, yes, let's go. And then it's like they're in their own world, owner doc is in her own world, and our worlds are never colliding. And then that associate doc moves on, and owner doc absorbs those patients or passes those patients on to a new associate, and they're like, oh my gosh, this was a mess of...
So, but how do you think that happens? Do you think it's because of, one, the assumption that this is another doc and they know what to do, so there's lack of communication and calibration? I would imagine that's a lot of it. And the other part is the ickiness of it. Like, do I really have to babysit and handhold and be the bad guy?
It's totally both of those.
We're all dentists, 4 out of 5 dentists all do different things. And so, you know what, they went to dental school. They probably know what they're doing.
Yep. It is absolutely both of them. It's awkward all the way around. For whatever reason, it's awkward to have these kind of calibration type conversations.
What about if it's the opposite way? What if it's the associate that's like, okay, I sat in on this doc's work and the owner doc left an open margin. Owner doc missed that. Like, do you ever see it that way?
Very seldom, but when I do, I've got one associate in mind that this was happening, where she was like, what the heck is going on? And so my challenge to her was, ask for these meetings. Ask to see if you get together once a month with the owner doc, and she brings a case and you bring a case, and y'all dialogue about it together. So associates have the power to ask for that. And again, the owner doc may say, nah, I don't have time for that, don't really want to do it. And if that's the case, that may be the writing on the wall, where you're like, okay, I probably need to move on, because first of all, I don't agree with some of the clinical output here, and owner doc's not willing to talk about it. So all that to say, an associate can certainly vouch or push for one of these monthly type meetings.
I think the other thing that is super helpful, that is easy, and I think that can get missed, and it goes back to communication, but as owner doc, checking in with your team.
Yeah.
And so for me, especially the first couple of months, if I remember correctly, I would say, okay, how did that day go?
Yeah.
What went right? What went wrong? Did anything stick out to you as being weird? And what we don't want is the assistant or the hygienist or the front person saying, well, that's not how Dr. Kuba would do it. Like, if I was an associate, I would be like, well, I'm not Dr. Kuba. So, so it's got to be very respectful. But so for us, for example, I think the MOD example, I think my, as the front was putting that treatment plan together, and then the treatment coordinator was about to go over it, they already were like, the hell is this? Like, they'd never seen an MOD treatment plan on a primary tooth in our office. And so they were like, the hell is this? Was this a mistake? And then, the rumblings of, no, it's a new doc over there, like, saying to do this. Then that treatment coordinator going and saying, can I just make sure this is what you want a treatment plan? And I know you're a doc, but I just know we typically, a lot of times, even just the person saying that, the doc is like, what, why? Mm-hmm. Why are you asking this? Mm-hmm. Well, I've just never seen Dr. Kuba treatment plan a MOD composite on tooth number A. Like, I just have never seen that. And none of the other associates that have been here have ever done that. So I just wanted to make sure that this wasn't a mistake. Right. So that may be the nicer way of doing that. And I think that's what happened, where that doc then, the next time I was there with him, he was like, okay, clearly I missed the mark on here, and I want to make sure I'm doing things the way you do them. So he was very gracious about it. But what, I think that leaning on your team to make sure they do it in a respectful way, but they're your spies, basically, like, tell me what, or my current associate doesn't say much. He's not fazed by much, which is so great in so many ways. But then I'm like, were there things that either A, he missed and is unaware of, and this is about to, like, I'm about to come back and have to deal with this pile of, what, and he's clueless about it, or did he just think it wasn't a big deal or whatever, right? And so I'll ask my team, hey, how did IV day go?
Yeah.
Any hiccups, any issues, any parent issues, any concerns, anything we need to improve upon next time? So not even for a picking on the doc, but as far as the flow went, or we have a new assistant, how did she do on IV day? How did she do on her first day? Like making sure you take the time to check in with your people to see, because sometimes they'll bring it to you, but a lot of times they're just like, oh, well, this is how it is. And, you want to make sure that, or vice versa, that the associate doc is not going to, harbor something going, okay, these assistants are driving me crazy.
Yeah.
With Dr. Kuba wouldn't do that. Well, Dr. Kuba does it this way. Well, Dr. Kuba does it that way. So luckily, my assistants rock. They're not going to ever do that. But that happens frequently in other offices. And you don't want to where you've done all this work to onboard this associate, and then the team is the one who chases associate off.
Right.
And you were none the wiser.
Yeah.
So that's a lot of treatment planning and blah, blah, blah. What do you do in the case of if you see crappy dentistry?
Yeah.
Because that's the other one where I'm like, how do I tell you your SSC is yucky?
So I actually had a practice owner that he was concerned about the quality of work that was being put out. Now, his expectations were very high on himself and on others. So incredibly detail-oriented. Every line of that composite needed to be perfection. But we started doing these clinical collaboration meetings, and because he was seeing things that he didn't like, he was able to bring those up. And so they would talk clinically, like, hey, this is how a treatment plan, blah, blah, blah. So they'd have a good clinical collaboration. And then he would bring up, hey, by the way, as I was auditing, because again, from the get-go, he makes it clear, like, hey, I do audit, not every case, but just kind of pick a few, throughout the month, and I'm auditing those cases. If I see any concerns, I'm going to bring those to you. So he had set the stage with this associate. And so in the clinical collaboration, he's like, hey, by the way, I had a concern that I wanted to bring to your attention. Hey, look at this filling. You see this. I feel like this could have been cut better here, this blah, blah, blah. And so he talked through it. And then from that was like, I want you to take pre and post x-rays on your fillings, and I want you to take pre and post IOPs on any filling that you do for this next week.
IOPs, intraoral photos.
Sorry,
okay.
Intraoral photos, yes. So I want you to take those. Let's revisit this next week. So let's not wait for our monthly clinical calibration, but just for this next week, can you have a real extreme?
So what do you tell the patient? I'm going to take an x-ray now after. I'm going to take a photo after. Like, what do you not even address it with the patient?
You don't even address it.
Okay.
You just do it. Hey, our doc really wants to check with the x-ray to make sure that everything looks perfect. We want a perfect filling for your tooth. So we're going to do an x-ray afterwards, and I'm going to take a couple of pictures.
But even if you didn't even say anything, they may not even notice that you're doing that.
They wouldn't even notice.
I mean, I guess an x-ray they would, but an IO, they may not even notice.
Yeah, very, very little will push back against that. But what I like about this strategy is that for that next week, because it's just like hey, let's focus on this thing and then let's revisit it next week. So it's a short timeline, because you don't want a bunch of crappy dentistry going out for a month. You want to be able to address it quickly. But what's great about it is there's a tangible next step. Take pre and post on your fillings, x-rays, take pre and post IOPs. Heck, take photos during the prep if need be, so that you can see how does that prep look. Do that for this next week, and then we'll get together and meet about it. The actual process of daily, as that doc does a filling, he or she is taking a pre and post, she's taking IOPs, or her assistant is, but she's becoming aware throughout that week of either inconsistencies or things that she doesn't like. But then you've got this end meeting where it's like, oh, at the end of next week, let's go back and look at some of your photos. The doctor, the owner doc, can see, was there improvement? Do we have the capacity to improve? Can he or she actually see the errors that are occurring? Or is she like, yeah, look at that pre and post x-ray, look at the photos, that's a beautiful filling. And the doc's like, oh gosh,
So what do you do in that case?
Then to me, it's like, okay, we're going to have to part ways. Because if that associate doc is looking at it as perfection, and that owner doc is looking at it like, I would not put that in anybody's mouth. There is, to me, too much of a clinical gap that we would not be able to close.
So do you write that into the contract, like the first 3 months are where we're going to be checking your work and if clinical proficiency, or are you stuck with this person because you have a contract, or
so
what?
any contract should have an out clause. Usually that's a 30-day notice that either party is able to give the other. Sometimes it's longer, but I prefer the 30-day notice, because I see it from an owner doc standpoint. I want that owner doc to be able to go, hey, by the way, I'm giving you your 30-day notice. This is the stated reason why. And that contract should be able to say that you can give that.
But how do you say that? We're just clinically not on the same page?
Yeah.
Like, how do I say, I think your dentistry's crap?
Well, to me, if you've had a couple of these, like, corrective type, hey, this filling was off, let's do this, he or she's going to know it's coming.
Okay.
So it kind of gets some of the awkwardness out of the way, and then you're just like, hey, I've done a lot of thinking on this. I don't think this is a gap that we can actually close. You look at a filling and you call it good. I look at a filling and I say that's an F filling. And again, that's just us not being able to see things from the same direction. But if a couple of these conversations have already happened, he or she knows that that's coming. So
I think I like this, because now as I'm looking to narrow down, whoever I'm bringing on, I think that's what I'm going to do is say, and I'm sure you say it too, there's a lot of collaboration. We want to make sure we're on the same page as far as treatment planning, verbiage for parents, and then asking for, giving them the heads up, hey, I'm going to be taking intraorals before and after and x-rays, so that we can just make sure, it's our quality control. Certainly if you see something of mine, you're welcome to bring it up to me.
Yeah.
And I want you to be able to ask questions, but, doing our due diligence to make sure you're successful in our practice. There's a certain amount of autonomy I want you to have, but there's also a certain amount of, you got to do it our way. And so we're just going to be making sure. So certainly the team is a valuable resource. They're more than happy to answer for you the what and why. Mm-hmm. Like if you were going to go in and you were going to go, extract premolars and just offer nitrous, that's appropriate sometimes, but, use the staff, lean on them to say what has typically been done here and why. Will this be a successful treatment plan or not? I mean, it may be what we want, but no parent is going to agree to it. So we've got to make sure we're all working in the same boundaries of things for us to reach our common goal of getting the kid the care they need.
Exactly.
And so my staff is a resource for you. Please use them. They'll be giving you feedback. I'll be giving you feedback, and I'm sure you'll be giving us feedback too on things.
Yeah.
But just be very clear with that, because that's the one thing where I'm just like, the treatment planning part of it, and then the actual dentistry part of it. Yeah, that I'm just like, how would I tell a colleague, I think your work is garbage? Like, I don't know that I could actually say that. Yeah. But now you've given me tools that I don't have to say that, but we can allude to it, that we're just not on the same page.
Yep, exactly. Okay. And to me, again, this is the practice owner's responsibility to do this. This, to me, is not elective or optional things. You are responsible for those patients and the care that they're receiving. And if you're having a separate set of hands carry out the work that's necessary on those patients, then it's your job to oversee and to ensure that it's quality work that's happening.
Thanks for joining the conversation today. We hope that you are comforted in knowing that you are not alone, but we also hope that you're walking away with some really great tips and tricks to try in your practice. We value your feedback, so please take a few moments to rate and review the podcast. Finally, we want to make sure that we're covering the topics that matter to you. So track us down on Facebook, Instagram, and Twitter, and let us know what topics you want us to cover. As always, please know that we are rooting for you today as you manage your dental drama.